industries in the world demand as much scrutiny and regulation as pharmaceuticals. In medicine, quality is non-negotiable.
The World Health Organization.
Since 1948, the United Nations body, the World Health Organization, has been the foremost authority on pharmaceutical standards around the globe. Only companies who successfully pass their rigorous inspection process are awarded the World Health Organization pre-qualification standard. This seal of approval ensures customers that a brand of medicine meets the strictest safety and quality control standards in the world. Of 900 pharmaceutical companies, G.T.U Pharma is the only organization to have received this certification. Our facilities are equipped with state-of-the-art machinery explicitly designed to prevent cross-contamination by using continuous environmental monitoring. All our raw materials are procured solely from WHO or US FDA validated suppliers and are carefully audited before they are declared compliant. Our quality control laboratories and product testing departments remain at the forefront of our manufacturing process. A series of stability testing procedures allow us to guarantee that our medicines maintain their quality long after they've been delivered to pharmacy shelves. We have taken great care to simulate environmental conditions to ensure that medicines retain their efficacy and longevity in our particular climate. In accordance with WHO guidelines, our employees are highly qualified and regularly receive training in Europe and Japan, keeping us at the cutting edge of rapid advances in pharmaceutical research. Our quality guarantee makes us the only pharmaceutical company which can sell medicine to global bodies such as UNICEF and that are approved for sale by international markets. Today, G.T.U Pharma is the single largest exporter of pharmaceutical products. But more importantly, our WHO certification means that doctors and patients have access to the best quality medicines in the world at affordable prices. At G.T.U Pharma, we are proud of this achievement. We believe that our people deserve the same access to quality medicines and medical care the world over. Because where you live should not decide if you live.
සුබ උදෑසනක් යා ඔබ සියලු දෙනාම ඉතාමත් ගෞරවයෙන් පිළිගනු ලබනවා. G.T.U Pharma ආයතනය විසින් පවත්වනු ලබන මහජනතාව දැනුවත් කිරීමේ වැඩසටහන් මාලාවේ තවත් එක් දිගුවක් ලෙස අද දින මෙම මුහුණු පොත හා Zoom තාක්ෂණය හරහා පවත්වනු ලබන මෙම වැඩසටහනට ඔබ සියලුම දෙනාම ඉතාමත් ගෞරවයෙන් පිළිගනු ලබනවා. ඉතාමත් කාර්යබහුල අවස්ථාවක පවා අප ආරාධනය පිළිගෙන අද දින මෙම වැඩසටහනට සහභාගී වූ ප්‍රසව හා නාරිවේද විශේෂඥ වෛද්‍ය A.G.T.U පාදෙනිය මහතාව අපි ඉතාමත් ගෞරවයෙන් පිළිගනු ලබනවා. විශේෂඥ වෛද්‍ය තුසිත පාදෙනිය මහතා ගම්පොළ මූලික රෝහලේ විශේෂඥ ප්‍රසව හා නාරිවේද වෛද්‍යතුමා ලෙස සේවය කරනු ලබනවා. එතුමන් MBBS රාගම වෛද්‍ය පීඨය කැලණිය විශ්වවිද්‍යාලය, MD Obstetrician and Gynecologist University of Colombo. එතුමා විදේශ අධ්‍යාපනය ප්‍රසව හා නාරි රෝග පිළිබඳ විශේෂඥ අධ්‍යාපනය ඔස්ට්‍රේලියාවේදී හදාරා තිබෙනවා. එසේම එතුමන් ප්‍රසව හා නාරිවේද පිළිබඳ විශේෂඥ වෛද්‍යවරයෙකු ලෙස අම්පාර, නාවලපිටිය සහ මහනුවර ජාතික රෝහලේ සේවය කර ඇති අත්දැකීම් බහුල ප්‍රසව හා නාරිවේද විශේෂඥ වෛද්‍යවරයෙකු වෙනවා. විශේෂඥ වෛද්‍යතුමනි, අප ඉතාමත් ගෞරවයෙන් ආරාධනා කරනු ලබනවා ඔබතුමන්ට මෙම දේශනය පවත්වනු ලබන ලෙස. Sir, it's a great honor for us to have you here for today's webinar. I would like to warmly welcome you to conduct the today's webinar.
Thank you very much for giving this opportunity to talk on this hot topic. First of all, I would like to give my sincere gratitude to G.T.U Pharma for giving this opportunity. I hope all very good morning to all of you, and I hope you all are doing well and safe in this pandemic situation. And today I'm going to talk about COVID-19 infection and pregnancy, what you should know. Well, I would like to give my lecture basically in English, but certain points I might discuss in Sinhala as well, because we have some non-medical participants as well. And so when the pandemic started 2019 December in Wuhan city, China, so we have lots of unanswered questions. So we all the clinicians were in having a huge questions about pandemic and what is going to happen in obstetric population, what will happen to baby, mother. So we had lots of unanswered questions. But thanks to our clinicians and researchers, most of these questions now we have the answer today. So I'm going to talk on one of these hot topics, that is pregnancy and COVID-19. I'm sure you will get some sort of a knowledge regarding pregnancy and COVID infection. Well, I'm going to discuss these topics under these topics. So COVID-19 infection, global and local situation, and what is the effect on COVID-19 on pregnancy, effect of COVID-19 on the fetus. And one of the hot topic we were discussing for last 1.5 years is mother to child transmission. වෙනවිදිහකින් කියනවා බබාගෙන් අම්මට මේ ලෙඩේ යන ආකාරය ගැන, and little bit of antepartum, intrapartum, postnatal management of COVID patient. And another hot topic currently we are discussing vaccination against COVID and pregnancy. So these are the topics I'm going to discuss within next 30-40 minutes. So this is what we saw during last 1.5 years. This is the timeline of COVID-19 infection. So in December 31st, 2019, the Wuhan city, the Chinese government warned the world that they are been witnessing pneumonia of unknown origin. And they were give the message to world population that they are seeing a kind of an infection which is very severe. And they started investigating this pneumonia, and they later discovered that it is the pathogen was discovered, and it was coronavirus. And very quickly, it started from Wuhan city, and very quickly it spreaded throughout the world. Therefore, WHO declared it was a global emergency in January 30. And researchers recognize the virus or the pathogen as coronavirus, and WHO initially it was named as a novel coronavirus, but February 11th, WHO gave the official name of the SARS-CoV-2. And then it spread everywhere in the world, and in February 26th, 2020, the first case was detected in Latin America. And meanwhile, WHO declared it as a global pandemic in March 11th. And we witnessed our first case as a COVID patient in March, probably middle of March 2020, one of the tour guide. So we had our first COVID patient last year. And of course, by March, May, the Wuhan city, the epicenter was shifting from Wuhan city to the Europe. And then we witnessed some horror pictures in the television that people were dying. And we saw how New York City suffered from this pandemic. And of course, people were dying and millions of people was getting sick. And at the same time, our researchers didn't give up the fight against the corona. And May 2020, we got the first news that first experimental vaccine from Oxford University was launched, and that was kind of an oasis in the middle of the desert for people who are suffering from this pandemic. So the first experimental vaccine was launched in May. And later, we witnessed the first treatment for COVID-19 infection, that is recovery trial came out, and that the dexamethasone was one of the drugs which can be used in oxygen-dependent ICU patient, and that improved the mortality. So that trial was out in July. And by September, world witnessed 1 million deaths. And by November, the second trial was out, that is on remdesivir, that is also improved the recovery in ICU patient. And by December, we got the information from the Oxford and UK, the first person to be vaccinated by December 8. So that is kind of a light we found through the tunnel. So currently, the whole world is dependent on this vaccine. And we were fortunate to get the first vaccine and the first Sri Lankan to be vaccinated in February this year. And lastly, the first Sri Lankan pregnant woman was vaccinated in June. So this is roughly the timeline what we have witnessed during last 1.5 years. So what is corona infection? So it is caused by severe acute respiratory syndrome coronavirus 2, and which belongs to the beta coronavirus subgroup, where SARS and MERS also included. And we know how it transmits, and its transmission mainly through a close contact with an infected person or from contaminated surface. And virus is viable on plastic and stainless steel up to 72 hours, and on cardboard up to 24 hours, and in aerosol for many hours. It's roughly about incubation period 5 to 7 days. And worldwide fatality rate is 0.1 to 1% in various studies. Well, this is the global situation where I got this information last night from the Johns Hopkins University coronavirus dashboard. You can see 183 million cases worldwide so far, and more than 39 million deaths occurs, and USA leading and India following them. And so still the world is suffering from this pandemic, even though 3 billion vaccinated at the moment. So this is what I got last night. In Sri Lanka, we had 262,795 cases with 3,157 deaths so far. And our country have vaccinated so far 4.1 million, more than 4.5 million cases. Little bit of our pregnant mothers, more than 1,900 mothers have been positive for corona infection. And I got the information that majority of them in the Western province. And currently 139 mothers in the critical care and in ICU. And unfortunately, we lost 13 mothers so far. So fighting against corona still continues. So what does COVID do in pregnancy? Pregnant doesn't appear to increase susceptibility to acquire the infection. That means if you are pregnant, that doesn't mean that you are having a high risk of getting the infection. But if you get the infection, and then of course you are having high risk of getting the complication. Garbani una කියලා අපිට corona virus එක අනිත් අයට සාපේක්ෂව වැඩිපුර හැදෙන්නේ නැහැ. හැබැයි ගර්භණී මවකට කොරෝනා හැදුනොත් ඒකෙන් සංකූලතා එන්න තියෙන ප්‍රමාණය අනිත් අයට වඩා වැඩි. So that is why pregnancy is so important, so special in managing corona patient. And fortunately, majority of pregnant mothers, they are asymptomatic. One of the study done in UK, PregCov-19 Living Systematic Review. So more than 2/3 of the pregnant population, luckily, අපේ 3/2ක්ම රෝග ලක්ෂණ නැති අය. ඉතින් ඒ හින්දා තමයි සමහර රටවල් යුනිවර්සල් ස්ක්‍රීනින් එකකට ගිහිලා තියෙනවා. ඒ කියන්නේ හැම ප්‍රෙග්නන්ට් අම්මා කෙනෙක්ම වාට්ටුවට ඇතුල් වෙනවා නම් ක්ලිනික් එකට එනවා නම් ඒගොල්ලෝ ස්ක්‍රීන් කරනවා කොරෝනා. ලංකාවේ තාම ඒ තත්ත්වයට ඇවිල්ලා නැහැ. මොකද majority of pregnant mothers are asymptomatic. So it is that's why some of the countries advise to do universal screening. And most symptomatic women experience mild to moderate flu-like syndrome. So that's again a good thing. So these are the symptoms and signs of COVID infection, which is very similar to non-pregnant people as well. So there is no difference in getting of symptoms of pregnant and non-pregnant people. So fever, dry cough, sore throat, difficulty in breathing, diarrhea, loss of taste and smell, chest pain, nausea, vomiting, and maternal pyrexia, tachycardia, hypotension in severe patients. They have tachypnea, oxygen saturation less, and baby also having fetal tachycardia. And sometimes others get confused and reduce urine output. So if you have a contact history and if you have those symptoms, so these are the tests we all are very familiar with. RT-PCR, which is the gold standard of diagnosing COVID infection, whether in pregnancy or non-pregnant. So it's diagnosed the current infection, and which has a very high sensitivity and specificity. So it is the best test. Only issue with that, it takes about 8 hours, but that depends on the facility. Roughly within 8 to 12 hours, we will be able to get the results. And the other test is rapid antigen test, again, which can be used to diagnose current infection. But unfortunately, the sensitivity compared to the PCR is less, but its sensitivity is high if patient is having symptoms. So symptomatic patient, the sensitivity is high. And sometimes we use serology, the blood we check to diagnose the previous infection, but not very much currently use this test at the moment. So what are the effects on pregnancy? So, COVID infection pregnancy to balapanico. So I told you the more than 2/3 of pregnant mothers are asymptomatic, but some of them get mild infection, but that means no evidence of pneumonia. And some people get moderate disease like viral pneumonia, and severe disease like pneumonia with oxygen dependent, and critical disease, that is adult respiratory distress syndrome, or maybe they end up in sepsis, septic shock. Sometimes they might end up in pulmonary embolism and coronary syndrome. And more importantly, the severe illness appears to be more common in latter part of the pregnancy. So පළවෙනි මාස දෙවෙනි තුන්වෙනි හතර මාස වගේ නෙවෙයි, අන්තිම මාස තුනේ මේ සිවියර් ඩිසීස් එකක් හැදෙන්න තියෙන chance එක pregnant අයට වැඩි. එතකොට අපි අන්තිම මාස තුනේ ඉන්න pregnant අම්මලා මේක ගැන දැඩි අවධානයක් ඉන්න. අනිත් අයත් ඉන්න ඕනේ. නමුත් severe illness එකක් එන්න තියෙන chance එක ඒගොල්ලන්ට ගොඩක්. And various researchers found that pregnant women with COVID infection have a higher rate of ICU admission and death. This is the important message I want to give you. If you are pregnant and if you get the disease and you are having a very high risk of getting admitted to ICU and unfortunately die. So you have to be, that is why you have to be very careful. Pregnant නම් ඔයාට COVID හැදිලා තියෙනවා නම් ඔයාට ICU එකකට දැඩි සත්කාරයකට ඇතුල් වෙන්න තියෙන chance එක අනිත් අම්මලාට වඩා ගොඩක් වැඩි. Pregnant නැති අයට වඩා ගොඩක් වැඩි. ඒ වගේම තමයි මැරෙන්න තියෙන chance එක ගොඩක් වැඩි. So death rates, various studies shows 0.1 0.14 to 0.8. But an important thing is මේ ප්‍රමාණය non-infected pregnant population එකට වඩා ගොඩක් වැඩි. එතකොට pregnant අයට මැරෙන්න තියෙන අවදානම ගොඩක් වැඩි. And the other important factor I want to tell you is pregnant mothers with COVID are more likely to develop mental health problems. So මානසික ආබාධ pregnant අම්මලාට තියෙන මානසික ආබාධ ප්‍රමාණය වැඩි COVID infection. One reason is they are isolated. The other reason is they're having loss of jobs, loss of the funds, and they are being quarantined. So they are being isolated. So all these factors make them to go into mental distress and stress. So pregnant mothers with COVID infection are very high risk factor for the mental health problem. So you have to be very careful. So effect on the fetus. So COVID infection එක බබාට කොහොමද? So one of the greatest study done for last 1.5 years is they have found that maternal COVID infection is associated with 2 to 3 times increased risk of preterm. COVID හැදුණා නම් ඔගේ බබා සති 37ට කලින් හම්බ වෙන්න තියෙන chance එක 2 ගුණයකින් වැඩි. So that is why we have to be very careful. Maternal COVID associated with preterm birth. And again, it's also associated with increased rate of cesarean section. So again, baba Caesar කරලා ගන්න තියෙන අවදානම ගොඩක් වැඩි COVID infection. Well, apart from that, there is no reported increased incidence of congenital abort. සංජානීය ආබාධ හැදෙන්න තියෙන අවදානම මේ COVID හින්දා වැඩි වෙන්නේ නැහැ. දැනට හොයාගෙන නැහැ. ඒ වගේම තමයි there's a slight risk there for stillbirth compared to other infections. So it is double with COVID infection. So මලදරු උපතක් ඇති වෙන තියෙන අවදානම සුළු ප්‍රමාණයකින් ඉහළ ගිහිල්ලා තියෙන සමහර ස්ටඩීස් වලින් අපිට ඒක පෙන්නනවා. And there is no increased risk of miscarriage. Don't worry about miscarriage or early pregnancy losses. It is almost same like non-COVID patient. And no increased incidence of intrauterine growth restriction. or බබාලා පොඩි වෙනවා කියලා එහෙම COVID හැදුනායි කියලා එහෙම පොඩි වෙනවා කියලා දැනට වාර්තා වෙලා නැහැ. දැනට. හැබැයි it might change in the future because currently lots of studies are going on. So what I am talking today might change in maybe 1 or 2 months or maybe years later. But at the moment, this is the new situation. Right. So this is one of the important topic I want to discuss is mother to child transmission. So what do you mean by in utero transmission? Garbhashaya ඇතුලේදී transmit වෙන එක ගැන මොකද හිතන්නේ? So to have an in utero transmission, the pathogens must be in the blood. So what are the pathogens? We are talking about the COVID virus. So coronavirus should be in the maternal blood and it should reach the placenta. And placenta is a wonderful structure where it has a huge barrier. So you need to break the barrier and cross the placenta and go to the fetus and infect the fetus. So this is what is happening in normal situation. For example, syphilis. So mother's virus, syphilis in the mother's blood, cross the placenta and go to the fetus and infect the fetus. But not like those syphilis. What we have found currently is viremia or the COVID infection found in the blood is very rare. So only 10% of the pregnant mothers who are especially critically ill patients are getting viremia. And even though the viremia present in 10% of the blood, only 1% will cross the placenta. So basically, transplacental transmission of COVID virus is negligible. So placenta එක හරහා COVID virus යයි කියලා අපේ අයගේ බීතිකාවක් තියෙනවා. ඒ ගැන පසුතැවිලි වෙන්න එපා. එහෙම යන්න තියෙන අවදානම ඉතාම අඩුයි. 100%කටත් වැඩියයි. So don't worry about the transplacental transfer. Remember that. So the other way that mother can give the virus to the baby is during the delivery. Deliver කරන අවස්ථාවේදී virus එක බබාට යනවා. So researchers have done lots of research on whether these viruses are present in the vaginal secretion. යෝනි තරලේ මේ virus එක තියෙනවද කියලා හොයාගන්න පරීක්ෂණ කරලා බලන්න. So they found out only 2% of the sample it was positive. So you don't have to worry about the vaginal secretion. Only 2% positive. But you know that during labor, mother will pass feces. So they found that more than 50% of fecal sample, this virus is positive. So of course, there is a point here. If you have a vaginal delivery, and if the baby is contaminated with feces, of course, there is a chance that baby might get the infection. Otherwise, vaginal secretion, you don't have to. So, බබා සාමාන්‍ය විදිහට හම්බ වෙනකොට ඒ වෙලාවේ අම්මා මල පහ කරලා තිබුණා. ඒ වගේ වෛරස් එකේ තියෙන chance එක ගොඩක් වැඩි. එහෙම වුණොත් චූටි අවධානමක් තියෙනවා බබාට වෛරස් එක යන්න. So breast milk transfer. මව් කිරි එක යනවා. නෑ. Very rare in breast milk. So therefore you don't have to worry about feeding the baby. The other way that mother can give the virus is from the mother's respiratory secretion. Yes, we call it horizontal transfer. Yes, so mother can give the virus to the baby through her respiratory secretion. So in nutshell, the basically two main methods that mother can transmit the virus. The one thing is from her respiratory the secretion, and the other one is contaminated with feed. So you don't have to worry about breast milk. You don't have to worry about the transplacenta. That will transmit very, very rare or in negligible amount. And important thing is whatever the data suggests that neonatal infection, if the baby get the infection, say me marga dekin monarikin babata hamuna again. So most babies are asymptomatic or mildly symptomatic. So you don't have to worry. Baby, whatever the babies get is very asymptomatic or mild symptomatic infection. Right. What are you going to do if you see a patient in the antenatal period? So our ward, Gampola Hospital, we have done lots of modification to take this COVID patient. So far, we have managed 10 to 15 pregnant mothers with COVID patient in Gampola Hospital. Of course, we have done lots of modification in the ward. So these modifications you have to do if you are dealing with pregnant mothers, and especially less number of antenatal visits. So you can't bring these mothers every day because she will give the infection to other mothers. So especially if the mother is low risk, so you can tell the mother that you don't have to worry about too much. And you can use telephone or video conferencing. And these are very important. Even in my ward at Gampola, we have given a hotline number. So patient or the midwife or whoever can contact the ward regarding any of the issues regarding the COVID. And healthcare workers should wear appropriate protection. So all of my staff are wearing masks, face shield, hand sanitizers when you're dealing. And there is no difference between pregnant mothers with COVID and pregnant mothers without COVID. So the routine antenatal tests are the same. But you have to be very alert, as I told you before, maternal anxiety, depression, and as well as the domestic violence. So the psychological issues they are undergoing during this period is so much. So you have to be very alert on this situation. Say if no one complains of any symptoms of COVID infection, so you have to inform the PHI, PHM or the MOH and arrange rapid antigen test or the PCR. If positive, and you have to do the contact tracing, and we will admit the patient to the ONG unit. And what we normally do is in the ward, if they are asymptomatic, we discharge after 10 days. And rest of the 4 days, we ask mother to be in the home quarantine. And when the mothers are in the ward, we monitor them daily with pulse, respiration, blood pressure, temperature, oxygen saturation, and we do some blood, CRP, full blood count, very regular. We look for daily status. And if patient develop symptoms, of course, we have to arrange multidisciplinary meeting, which involve various other specialties. We will discuss it later. So in labor, if what our main aim is to defer the delivery until the viremia shedding is complete, or until she complete her isolation period, if possible. So because we don't want to give the virus to other staff members, or so that's why we defer the delivery until the if as much as possible. If possible, we can wait till the viremia or the isolation period is over. So we have done lots of modification in the labor room. We have isolation room and all staff wearing full personal protection equipment if we are dealing with a pregnant mother with COVID, and minimum number of staff as well. And it's a real challenge wearing a PPE and managing a mother in the labor. So it's so distress, and it's like huge stress for the staff as well. Wearing a personal protective equipment and managing a labor is a huge task. My staff, I hope almost all the staff in this country have managed so far. And the other important thing what we have to understand is timing and mode of delivery or induction method, whatever the things, depends on the obstetric factor. So whether COVID will not tell us the mode of delivery or induction time. So it's almost like a non-COVID patient. And we need to have a multidisciplinary meeting, especially we need to have a neonatologist, anesthetist. And if we have a COVID patient, we will arrange a plan. So those are really important in managing patients in labor, especially anesthetists and the theater staff. We don't know, so we should inform this team beforehand, and then they can have a sort of a preparation before patient comes to the theater. And whatever the labor monitoring is same like non-COVID, so electronic combined fetal monitoring, and we maintain the partogram, and we monitor them by blood pressure, pulse, respiration, temperature, and oxygen saturation. And analgesia like a non-COVID patient. And if you give Entonox, mother should be given a separate mouthpiece to get the Entonox. And if facilities are available, the better to get an epidural analgesia, because that is one of the good things. If mother end up in a cesarean section, we can convert into Caesar as well very easily. And that will prevent general anesthesia being given to mother. And the other important thing in the labor room is that we have to anticipate the emergence and should have a backup plan. Then, of course, it's easy to manage these patients. So in the theater, again, we have a separate theater to manage COVID patients, and all staff should be wearing this personal protective equipment. And again, we have to have a minimum staff for the surgery. At the same time, we need to have a very senior staff who have the ability to deal this kind of a situation. And we have to have a kind of a plan again, and have sort of a backup plan as well, and avoid obstetric emergencies as much as possible, because arranging a Caesar, even an elective cesarean section, it takes about few hours. So even so in an emergency situation, of course, it's panic, patient panic. So it takes lots of time. So if you can avoid any obstetric as much as possible, that would be easy to handle this sort of situation. And of course, you need to have a kind of drill practices by wearing this personal protective equipment, because it's really challenging wearing a personal protective equipment and do a surgery. So I hope it's a kind of a nightmare. So there are a little bit of critically ill patient, obstetric patients management. I just want to give some sort of a idea about the principles of management of critically ill patient. So our aim is to stabilize patient's condition with standard therapy and save the mother and the baby. Aramuna ammai dennama dennagema jeevitha beragena. So for that, we need multidisciplinary team involvement. So we need physician, chest physician, we need anesthetists, hematologists, and theater people and obstetricians. So we discuss, we have a multidisciplinary meeting and discuss the management plan, especially in critically ill patients. So we monitor them respiratory rate, heart rate, blood pressure, oxygen saturation, urine output. It's very important to monitor them both absolute value as well as the trend, hourly trend. That will give us the idea of fluid management in the critically ill patient. So our target is to maintain the saturation between 94 to 98. And it is important to have a meticulous fluid balance, especially it's a real challenge, pregnant woman's fluid management. So we have sort of a guideline, so we stick to those guidelines, and meticulous fluid management is really important. And if we suspect bacterial infection or the sepsis, we can start antibiotics after consulting the microbiologist. And another important aspect is to assist the mother for a risk of venous thromboembolism. Pregnancy is a high risk factor for thrombosis. So COVID infection, again, the high risk factor. So we have to assist the mother and arrange maybe low molecular heparin or maybe stockings or whatever the things. So multidisciplinary meeting will discuss all these things. And the famous recovery trial give us the one of the magic drug, steroids, that can be given to 10 days and or up to discharge or whichever the soon. Well, we normally give steroids to pregnant mothers in to lung for the baby's lung maturity. So if we think of delivering a baby early, we need to give the sort of a steroid to baby's lung to be matured. So we normally give for that, the drug is dexamethasone. But unfortunately, what we give in COVID patients is prednisolone or hydrocortisone. That will not cross the placenta because whatever the drug, the prednisolone or hydrocortisone is metabolized in the placenta, a very negligible amount reach the baby. So if you want to give steroid for the lung maturity, you have to give dexamethasone plus the other steroid for the treatment of critically ill patient. And again, another studies reveal that remdesivir, again, we don't know the effect of remdesivir on pregnant mothers. So again, if you want to start remdesivir, of course, we need to have a multidisciplinary meeting. And if we think that benefits is more than the risk, of course, then we have to give remdesivir. And the other drug is interleukin-6 receptor antagonist, tocilizumab. And again, we don't know the effect of tocil on pregnant mothers as well as the baby. So, but again, with multidisciplinary meeting, we can add TOS to the pregnant mothers as well. And rest of the drugs have not very effective hydrochloroquine, retinol, azithromycin have shown not very effective on managing critically ill pregnant mothers. Well, of course, sometimes we may have to or give up the procedure, whatever the drugs we give, and we have to have a sort of a multidisciplinary meeting, and we may have to deliver the baby to save the mother's life. So those are the critical situation, and we have to have a delivery plan on this, because sometimes whatever the treatment we give, will not give any benefit to the mother. So සමහර අවස්ථාවල අපි මේ දින බෙහෙත් එකක්වත් වැඩ කරන්නේ නැති අවස්ථාවල් වෙන. ඒ වගේ අවස්ථාවකදී අම්මගේ ජීවිතේ බේර ගන්න අපිට සිද්ධ වෙනවා බබාව කලින් සීස කරලා ගන්න. ඉතින් ඒ වගේ decision එකක් කරනකොට ඉතාම සංවේදී, very sensitive issue. So we have to have a discussion between family and the multidisciplinary meeting, and so we have to have a kind of a plan. So it's a huge decision, but sometimes we may have to take that decision. So a little bit of postpartum management of pregnant mothers with COVID. And we know the benefit of breast milk, and it was well established. And various studies we have done, and then found that the neonatal infection is very rare, something like 5 per 10,000 live. So body neonatal babekuta infection එකක් යන්න තියෙන chance එක ගොඩක්. So then at the very beginning of the pandemic, we were very clueless whether to give the baby to the mother or not. So at the initial days of pandemic, we separated the mother and the baby because we didn't know that during breast milk or the transplacenta or whatever the way we thought the infection would transmit to the baby. But now we found that there is very negligible amount of transmission through breast milk and vaginal secretion and the transplacenta. So the current practice is we will not separate the baby from the mother. Or අපි බබා හම්බුනාට පස්සේ බබයි අම්මයි අපි කලින් වෙන් කරා. නමුත් දැන් අපි ඒක කරන්නේ නැහැ. මොකද අපි හොයාගෙන තියෙනවා බබාට හැදෙන්න තියෙන chance එකත් 10000කට 5ක් 6ක් විතර. ඒ හැදුනත් හැදෙන්නේ ඊටාම mild infection එකක්. ඒ නිසා නමුත් මව් කිරි දෙන එක ඊට වඩා ගොඩාක් advantages තියෙන නිසා අපි දැන් බබා කෙලින්ම බබා හම්බ වෙච්ච ගමන් අම්මට දෙන්න. So what we practice is the what you call kangaroo care, or skin to skin contact practice after the delivery. So all beforehand we have to advise the mother that we are going to do after the delivery. So it's kind of a counseling is important before the delivery. And so COVID-19 is not a contraindication for breastfeeding. So that's what I was discussing these things. So there are certain things that mother should practice. So good hygiene is really important before handling the baby. So mother should have hand washing, avoid coughing or sneezing on baby, and she should wear a proper face mask. So with all these things, she can minimize the transmission of virus from mother to the baby. And remember, baby should not wear a mask because risk of suffocation is there. So we don't normally put a mask to the baby. And unwell and critically ill patients are there. Of course, we used to give the express breast milk or by using a hand pump or the breast pump. And make sure that you do the proper sterilization when you take express breast milk. And again, of course, we have to be aware of postnatal mental health as well. And when we discharge from the ward, we have to inform the MOH, PHI, and PHM regarding what we have done in the ward. Right, come to the most interesting topic in my lecture: vaccination and pregnancy. Well, I still can remember people were gathering in the what do you call that, penny polymer. ගොඩක් අය ඔහුගේ මාස කාලේ penny polymer හිටිය දහස් ගාන. But අපි ඒකෙන් ලබාගත්ත දෙයක් නෑ. So remember, vaccine is the best long-term solution. No penny. Penny නෙවෙයි පිළිතුර. Vaccine එකයි long-term solution එක මේ current pandemic. So more than 200 vaccines have developed so far, and 20 vaccines have entered into the phase 3 trials, and 7 of these vaccines have been approved by the WHO for emergency use. But unfortunately, no vaccine has been tried on pregnant population. So there are no vaccine trials on pregnant population. But remember, there are reports that more than 100,000 pregnant mothers who have been not knowing that pregnant and who are taken the vaccine. And most of the researchers, they have followed these pregnant mothers who advertently given the vaccine without knowing that they are pregnant, and they followed them and they found that no effect on the baby. So even though the vaccine has not been done any trials on pregnant population, when we followed those pregnant mothers, we found that there's no harm. So extrapolating these vaccines into the pregnant population, so we found that vaccine will prevent infection as well as minimizing the severity of the disease. So that is the main advantage of vaccine. May prevent corona infection. එතකොට ඒ වගේම තමයි severe disease එකක් එන්න තියෙන chance එක ගොඩක් අඩු කරනවා vaccine වලින්. So that is one of the main advantage of vaccine is it will prevent infection and minimize the severity of it. Not only that, vaccine will reduce the risk of preterm birth. So we know that one of the risk factor, one of the complication of pregnant mothers are facing is they tend to have a preterm birth. බබා කලින් හම්බ වෙන්න තියෙන අවදානමක්. So vaccine වලින් මේක අඩු කරනවා. So ගොඩක් වාසියක් වෙනවා. අඩු මාස වලින් බබා හම්බ වෙන්න තියෙන අවදානම අඩු කරනවා මේ vaccine. Not only that, vaccine will reduce the transmission of virus to the household. If you are a pregnant mother and get the disease, and if you are vaccinated, so the transmission of virus to the family members will reduce. So that's a real advantage for your family. And vaccine will protect newborn from COVID by passive antibody transfer. So if you are being vaccinated, this antibody will cross the placenta and goes into the baby. So baby will have a bit of an immunity, even though it's not a long lasting, but it's a good immunity. So again, it's a real advantage of vaccine. So this is what I have discussed. So huge advantage of getting a vaccine for a pregnant population. Of course, there are some risks associated with vaccine as well. So you may have minor local reaction, pain, redness, swelling, and some systemic adverse effect like fatigue, headache, mild body aches, pain, වගේ පොඩ්ඩක් වුණා වගේ ඇඟපතේ වේදනාව වගේ ඒ වගේ දේවල් එන්න පුළුවන්. Very rare thrombotic event can happen, especially after Oxford AstraZeneca vaccine. And so far, we have not detected any harmful effect of vaccine on the fetus. But who knows? We don't know. But so far, we have not detected any harmful effect. So can we give the vaccine to the breastfeeding? Yes, you can. So if you are breastfeeding, if you are interested in getting the vaccine, yes, you can. So no need to stop breastfeeding just to have the vaccine. Vaccine එක ගන්න කියලා breastfeeding නතර කරන්න අවශ්‍යත් නැහැ. ඔයාට pregnant බබා හම්බුනාට පස්සේ කිරි දෙනවා නම් vaccine එක ගන්න. And if you are planning for a pregnancy, or say if you are going for a fertility treatment, so බබෙක් බලාපොරොත්තුෙන් ඉන්න අයට මේ vaccine එක දෙන්න හොඳයි. කිසි ප්‍රශ්නයක්. කිසි දෙයකට බය වෙන්න අවශ්‍ය නැහැ. So vaccine will not cause any harm or any delay in conception. So go and take the vaccine, and at the same time you go and take your fertility treatment. Vaccine එක ගන්නත් පුළුවන්, fertility treatment ගන්නත් පුළුවන්. මේකේ කිසිම බලපෑමක් නැහැ. So these are the 7 vaccines I was discussing about. So all have been given on pregnant mothers as well. And currently, Pfizer vaccine, there is a ongoing research going on in USA on pregnant mothers with the Pfizer vaccine. But of course, theoretically, all these vaccines are safe. So what we give in current practice in Sri Lanka is the Sinopharm which is an inactivated vaccine, which has 2 doses given 1 month apart. It has an 78 to 86% efficacy. So remember that. So it's even better than Oxford AstraZeneca. So, well, this is what we practice at the moment. So all vaccines are safe in pregnancy. But currently in Sri Lanka, what we have launched here is the Sinopharm vaccine. So we'll come to that later. So considering all these current pandemic, our college decided to recommend vaccine for pregnant mothers, preferably after first trimester. But remember, even in the first trimester, this can be given. So say if you are in a very high risk population where COVID infection is very common, of course, you don't have to wait till your first trimester is passed. So you take the vaccine. So පළවෙනි මාස තුනේ අපි සාමාන්‍යයෙන් කිසි vaccine එකක් දෙන්නේ නැහැ. නමුත් COVID virus එක පැතිරෙන ප්‍රදේශයක ඔබ ඉන්නවා නම් ඔයාට vaccine එක ගන්න ප්‍රමාද කරන්න එපා. මාස 3 ඉවර වෙනකන් කියලා ඉන්න එපා. vaccine එක ගන්න. So it is safe. But of course, we try to defer the vaccine after first trimester. But if you are in a high risk population, yes, you can take the vaccine. But for the currently, what we give vaccine is to high risk mothers. Not all mothers are being given the vaccine. And fortunately, we vaccinated our first mother last month. So this is the government circular issued on vaccination in pregnant mothers. So we have categorized 2 main groups of mothers to be vaccinated. The first group is the pregnant women who are at higher risk of severe disease, like age more than 35, BMI 30, diabetic, hypertension, heart disease mothers, malignancy mothers, chronic respiratory diseases, liver diseases, renal diseases, so blah, 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 various. So they give something like 10, 15 categories of high-risk mothers. So these mothers can be given the vaccine. The other main group is the pregnant woman with high risk of exposure to COVID-19, especially healthcare workers, or they are pregnant women who are working in the front line of management of COVID and essential services pregnant mothers. So these are the 2 main categories of pregnant mothers. At the moment, we give the vaccine. Right, we have come to the last slide of my lecture. So in nutshell, pregnant people with COVID-19 infection appear to be at increased risk for complication. So if you are pregnant, if you get the disease, yes, you are having a high risk of getting the complication. And you are having high risk of admitting to ICU or unfortunately death as well. But the other important factor you have to remember is if you are pregnant, if you get the COVID, you are having a 2 to 3 time risk of preterm labor. And the neonatal infection is possible through potential viral exposure in the maternal feces or the respiratory secretions. And vaccine can be given in pregnancy as well. And the bottom line is no vaccine. Any vaccine is safe than no vaccine in pregnancy. So that I conclude my lecture, and thank you very much for listening.
Thank you, sir, for that very informative presentation. I am sure it's a great value addition for all of us. We will be signing off from today's webinar. Thank you all. Have a good day.